Diarrhea, Acute Marie L. Borum, M.D., ed., M.Ph., M.A.C.P., F.A.C.G., A.G.A.F. Scott Baumgartner, M.P.A.S. Basics Description: an abnormal increase in stool water content, volume, or frequency, greater than or equal to 3 in 24 hours, for 14 days duration, secondary to either impaired water absorption and/or active water secretion, most commonly secondary to infectious etiology, often self-limited if diarrhea persists or becomes chronic. Consider non-infectious etiology. Acute viral diarrhea, 50–70%, most common cause of infectious diarrhea, non-inflammatory, watery, frequently presents with associated nausea and/or vomiting symptoms, usually develop after an incubation period of 1 day and last for 1 to 3 days, typically self-limited. Bacterial diarrhea, 15–20%, most common infectious cause of inflammatory, bloody, diarrhea. Incubation period variable, diarrhea caused by preformed enterotoxin presence within 1 to 6 hours of contaminated food ingestion, whereas bacterial infection typically presents within 1 to 3 days. Symptoms usually resolve in 1 to 7 days. Antibiotic use attenuates length and/or severity of disease. Suspect when concurrent illness in others who have shared potentially contaminated food. Suspect Clostridium difficile in patients with recent antibiotic use or hospitalization. Protozoal infections, 10–15%, typically cause non-inflammatory, watery, diarrhea. Long incubation period and prolonged disease course. Symptoms develop approximately 7 days after exposure and commonly last greater than 7 days. Suspect when outbreaks of watery diarrhea in areas with contaminated water or food supply. Traveler's diarrhea, TD, typically begins 3 to 7 days after arrival in foreign location and resolves within 5 days. Rapid onset, generally self-limited. Epidemiology in developing countries. Acute diarrhea is more common in children. No age predilection in developed countries. Acute diarrhea accounts for greater than 128,000 U.S. hospital admissions and 2.5 million annual deaths worldwide. 1. Prevalence: second leading cause of death in children 5 years and seventh leading cause of death among all ages worldwide. Affects 11% of the general population. Rotavirus and adenovirus most common in children 2 years. Bacteria are more common in children greater than 2 years in developing world. Acute diarrhea is largely due to contaminated food and water. 1. Etiology and pathophysiology: bacterial Escherichia coli, Salmonella, Shigella, Campylobacter jejuni, Vibrio parahemolyticus, Vibrio cholerae, Yersinia enterocolyticus, C. difficile, Staphylococcus aureus, Bacillus cereus, Clostridium perfringens, Listeria monocytogenes. Viral: rotavirus and norovirus. Most common, adenovirus, astrovirus, cytomegalovirus. In immunocompromised, protozoal: Giardia lamblia, Entamoeba histolytica, Cryptosporidium, Iosospora belli, Cyclospora. Microspora. Pathophysiology. 1. Non-inflammatory, most commonly viral. Increased intestinal secretions without disruption of intestinal mucosa. Watery character. Inflammatory, generally invasive or toxin-producing bacteria. Disrupts mucosal integrity with subsequent tissue invasion/damage. Bloody character. Viral diarrhea, changes in small intestine cell morphology, including villus shortening, increased number of crypt cells, and increased cellularity of the lamina propria. Bacterial diarrhea, bacterial invasion of colonic wall leads to mucosal hyperemia, edema, and leukocytic infiltration. Risk factors: travel to developing countries, failure to observe food/water precautions, immunocompromised host, antibiotic use, proton pump inhibitor, PPI, use, daycare exposure, fecal oral sexual contact, nursing home residence, pregnancy. 12-fold increase for listeriosis. 1. General prevention: frequent hand washing, reduces incidence of diarrhea by approximately 30%. Proper food and water precautions, particularly during foreign travel: boil it, peel it, cook it, or forget it. Avoid undercooked meat, raw fish, unpasteurized milk. Rotavirus vaccine, for infants, typhoid fever and cholera vaccine, for travel to endemic areas. TD prevention, Pre-travel counseling on high-risk food/beverage. Consider daily prophylaxis with bismuth subsalicylate, BSS, in all travelers, can reduce the risk of TD by up to 60%. Usual dosing of 2 tablets, 262 mg each, or 2 ounces, 60 ml. Liquid formulation 4 times daily. Do not use routine antibiotic prophylaxis when indicated. The Infectious Disease Society of America recommends chemoprophylaxis with fluoroquinolones, norfloxacin 400 mg/day or ciprofloxacin 500 mg orally once or twice daily. Fluoroquinolones are not recommended for prophylaxis by the International Society of Travel Medicine, which advocates the use of rifaximin 200 mg once or twice daily. 2. C. Probiotics, prebiotics, and synbiotics have unclear benefit as prophylaxis. Commonly associated conditions: inflammatory bowel disease, IBD, immunocompromised, HIV, malignancy, chemotherapy. Diagnosis: history, duration of symptoms 14 days, historical clues for dehydration, orthostatic hypotension, dizziness, increased thirst, decreased skin turgor, decreased N/or urine output, or altered mental status. Description of stool characteristics and output: frequency, quantity, consistency, character, presence of mucus, blood, or fat, floating giardia associated with pale, greasy stools. Weight loss associated symptoms: change in appetite, abdominal pain or bloating, nausea/vomiting, or fever. Recent hospitalization. Antibiotic or PPI use. Travel history: ingestion of raw or undercooked meat, raw seafood, unpasteurized milk. Sick contacts: immunocompromised state, pregnancy, daycare exposure. Sexual history, e.g., men who have sex with men. MSM, fecal oral contact, HIV, nursing home residents. Cirrhosis, associated with Vibrio, hemochromatosis, associated with Yersinia. Physical exam: assess degree of dehydration. 1. Ill appearing, dry mucous membranes, tachycardia, orthostatic hypotension, decreased skin turgor, delayed capillary refill, altered mental status, can be absent in early dehydration. Fever is more suggestive of inflammatory diarrhea. Abdomen, assess for distension, rigidity, rebound. Tenderness. Rectum, blood, tenderness, stool consistency. Geriatric considerations: fecal impaction or obstructing neoplasm can cause overflow diarrhea with chronic constipation. Differential diagnosis: IBD, malabsorption medications, cholinergic agents, magnesium-containing antacids, chemotherapy, antibiotics. C. Difficile colitis secondary to antibiotic use. Diverticulitis, ischemic colitis. Spastic, irritable, colon. Fecal impaction. Endocrinopathies, thyroid disease. Neoplasia. Diagnostic tests and interpretation: initial tests, lab, imaging, reserve laboratory testing for patients with persistent fever, moderate severe disease characterized by passage of greater than or equal to 6 stools per day, duration of greater than 72 hours, dysentery, profuse watery diarrhea, immunosuppression, or if suspected outbreak. 3. C. CBC: leukocytosis, anemia, blood loss, eosinophilia, parasite infection, thrombocytopenia, hemolytic uremic syndrome. Hus. Serum electrolytes: bun and creatinine may elevate with volume depletion. Non-onion gap: metabolic acidosis. Stool sample: occult blood, IBD, bowel ischemia, and certain bacterial infections. Fecal leukocytes, stool ova and parasites. Stool culture. For bloody diarrhea, consider Salmonella, Shigella, Campylobacter, E. coli 0157H7, Y. enterocolytica, E. histolytica. C. difficile toxin, especially IBD, recently hospitalized or recent antibiotic use. 4. C. giardia. ELISA 90% sensitive in at-risk population. Abdominal radiographs, flat plate and upright. If severe abdominal pain or concern for obstruction, abdominal CT scan is preferred to evaluate intra-abdominal disease. 5. C. Diagnostic procedures/other: consider sigmoidoscopy or colonoscopy in patients with persistent diarrhea, when there is no clear diagnosis after routine blood and stool tests, and if empiric or supportive therapy is ineffective. Consider colonoscopy in immunocompromised patients to evaluate for CMV colitis. Colonoscopy helps to distinguish infectious diarrhea from IBD, ischemic colitis, cancer, or other non-infectious etiologies. 5. C. Treatment. General measures. Oral rehydration and electrolyte management are key to successful treatment. Oral intake, as tolerated if the gut works. Use at balanced electrolyte rehydration solutions recommended in elderly and profuse, watery TD. 3. C4 fluids. If patient cannot tolerate oral rehydration or presents with severe dehydration medication. First line. Consider empiric antibiotics, fluoroquinolones or macrolides, in patients with signs and symptoms of systemic infection, severe disease, or clear cases of TD. 3. C. Fever, bloody diarrhea, fecal leukocytes. Immunocompromised host. Signs of severe volume depletion. Symptoms greater than 1 week. Tailor antibiotics to stool culture results. 3. C. Giardia, metronidazole 250 mg per TID for 5 to 7 days, tinidazole 2 grams per 1 C. Histolytica, metronidazole 500 to 750 mg per TID for 7 to 10 days. Tinidazole 2 grams per daily for 3 to 5 days. Shigella, ciprofloxacin 500 mg per bid for 3 to 5 days or ceftriaxone 1 to 2 grams IM/4 daily for 5 days. Campylobacter, azithromycin 500 mg per daily for 3 to 5 days or erythromycin 500 mg per QID for 5 days. C. difficile, vancomycin 125 to 500 mg per QID for 10 to 14 days. Or fidaxomicin 200 mg per bid for 10 days. Consider fecal microbiota transplant in recurrent mild to moderate C. difficile infections. TD, ciprofloxacin 500 mg per bid for 1 to 3 days. Azithromycin, if suspicion of quinolone-resistant pathogens, 500 mg per daily or 1 gram per daily for 1 to 3 days. Rifaximin 200 mg per TID for 3 days. Combined with loperamide 4 mg per initial dose, followed by 2 mg after each episode of diarrhea for maximum of 8 mg daily. Loperamide or BSS may be used alone in cases of mild TD. 2. C. General considerations. Antibiotics are not recommended in salmonella infections unless caused by Salmonella typhosa or if the patient is febrile or immunocompromised. Avoid antibiotics in patients with E. coli 0157H7 due to risk for hemolytic uremic syndrome, HUS. Antibiotics are not indicated for foodborne toxigenic diarrhea. Avoid antimotility agents, e.g., loperamide, in patients with febrile or bloody diarrhea, especially E. coli 0157H7, or antibiotic-associated colitis. Antimotility agents used in combination with antibiotics may speed recovery from TD. Antibiotics are not recommended for the treatment of mild TD. 2. C. C. difficile infections in IBD patients. Initially treat with vancomycin or fidaxomicin. Consider fecal microbiota transplant in patients with recurrent C. difficile infections. 4. C. Significant medication interactions. Salicylate absorption from BSS can cause toxicity in patients already taking aspirin-containing compounds and may alter anticoagulation control in patients taking warfarin. Avoid alcoholic beverages with metronidazole due to the possibility of a disulfiram reaction. Complementary and alternative medicine. Bismuth subsalicylate may help control rate of diarrhea stools. 3,6. C. Probiotics are recommended for prevention of antibiotic-associated diarrhea and C. difficile infection recurrence and to treat acute infectious diarrhea in setting of symptomatic IBS. 6. C. Probiotic use greater than 1010/G may help in patients with antibiotic-associated diarrhea. 2. A. Probiotic strains Lactobacillus rhamnosus GG, LGG, and Saccharomyces boulardii most effective, may reduce duration by up to 1 day. Avoid probiotics in immunocompromised patients. 2. A. Zinc supplementation can decrease diarrhea duration in children 6 months to 5 years of age who reside in countries with a high prevalence of zinc deficiency or who have signs of malnutrition. Admission, inpatient, and nursing considerations. Outpatient management, except for patients who are severely ill with signs of volume depletion. Ongoing care. Diet. Early oral refeeding is encouraged. Regular diets are as effective as restricted diets. The traditional bananas, rice, applesauce, toast, brat diet has little evidence-based support, despite heavy clinical use, and may result in suboptimal nutrition. During periods of active diarrhea, coffee, alcohol, dairy products, fruits, vegetables, red meats, and heavily seasoned foods may exacerbate symptoms. Patient education. See General prevention. Prognosis. Acute diarrhea is rarely life-threatening if adequate hydration is maintained. Complications. Volume depletion, shock, sepsis. Anemia. Hemolytic uremic syndrome with E. coli 0157H7. Guillain-Barré syndrome with C. jejuni. Reactive arthritis with Salmonella, Shigella, and Yersinia. Functional bowel disorders, e.g., post-infectious irritable bowel syndrome (PIBS),